Thank you for the introduction. I'm not very sure why Gus asked me to speak about lessons learned from the past. I'm not that old. But I'm very happy to do so. I'll speak about 3 interventions, prevention interventions: the contraceptive pill, hepatitis B virus vaccination, and human papillomavirus vaccination. And well, the idea of this talk is to look back, reflect on the lessons learned, and take them on to move further. Talking about sex is okay, but sometimes a bit complicated, especially when it's getting out of your comfort zone. And for some people, gay sex is out of comfort zone. And for some people, girls having sex is very much out of the comfort zone. Girls don't have sex, I mean, you know, like our daughters under the years of 20, they don't have sex today. So there's no need for human papillomavirus vaccination. It's a big debate, let alone oral contraceptives. Let's start with the contraceptive pill, and I found this on the internet. It's on the BBC site. It's archived like an old page, but it's still there, and it puts all arguments against the contraceptive pill here, and it's quite impressive. It's inherently wrong. It carries health risks. And then I like in the middle one, it brings bad consequences. It's the consequentialists' arguments. And then to the right, of course, it leads to immoral behavior. That's quite something. So let's go back and look into history. And I know the slide's very small, but I'll talk you through. It started all with the Egyptians. Ancient Egyptian women found some way to prevent their pregnancies, but we'll skip that part and go straight to 1914. And there you go, it started with an activist. It always starts with an activist, doesn't it? And soon there was a scientist working alongside the activist, and he did some tests, but he was really set aside as Frankenstein. It was seen as very immoral work that he did. It took another 20 years, up to 1952. Down on the slide, the race is on. By that time, several scientists were looking for a pill to prevent pregnancies. And there was not only an activist, so there was an activist and a scientist, and then there was one more thing that was needed, and that was money. So there was the good thing, there was someone who donated a large amount of money to enable the researcher to do the research. There was a first human trial, and it appeared to work. That was 1954. And then it took another 6 years for the FDA to approve the pill. Well, that's about the same time as the European Medical Association took to approve PrEP. Many similarities, I thought. It was approved, and it was, at least in the United States, an instant hit. A lot of women started to use the pill. But that was not the whole story. It remained for a long time illegal in at least 8 states, and the Pope was against it. There we have the doctors. Doctors were not fully supportive of it too. And in 1969, there was the doctor's case against the pill publicized, emphasizing on the health risks of the contraceptive pill, and even a debate in the Senate about it. I'll skip now all the way to 2000, and only then it was stated that the costs of the oral contraceptive pill must be covered by insurance. Mind the time lag. Some things took a long time in this implementation. We're not yet there. 2010, 50 years after the approval, there are still problems. lawsuits and debates about it. I skip back just a little bit to 1964. There was an article in The Lancet, one of the most important medical journals, speaking about little girls doing things that they're actually not really have the experience to handle, and that there was no absolute evidence that an increase in promiscuity would result from it. That was the type of language by then, 1964. And then there was one major milestone, and that was in Japan. Japan approved the oral contraceptive pill only in 1999, and they were one of the last countries to approve. 1999, that took almost 60 years. So, what can we learn from the introduction of the contraceptive pill? I think we can learn we need activists, and we need scientists, and we need money, but we also need to have patience and long-term commitments. Time spans are long. It's important to realize that doctors always will put the principle, do no harm, first. And that's why they may be not on the barriers for new interventions right from the start. And we know that religious forces can be strong opposites. That's what I wanted to tell about the oral contraceptive pill. Now quickly skip to the hepatitis B virus vaccination. In 1982, a safe and effective vaccine became available. And in the Netherlands, that resulted in 1993, a vaccination for healthcare workers, 1989, vaccination for babies of positive mothers, and then there was a pilot project for gay men and sex workers and for people who use drugs. 2002, it was implemented, free vaccination for these key groups, and a year later also from babies with a parent from an endemic country. We were late with universal infant vaccination. It only started in 2011, 6 years ago. So we have, and there was no backup, how do you say, lag thing doing. So we still have for quite a few years, there are key groups who are not vaccinated. What I liked about this is that it started with a pilot project. Like many PrEP implementation programs started with a pilot program, everybody getting used to it, getting some experience, and then continuing into rollout, like in Belgium, for example. I'll speak a bit more about a key group vaccination program that started in 2002. Because why did it work? What did we do to reach good coverage? Well, there were many vaccination sites, and I think that was one of the key opponents of the program. Here you can see a map of Amsterdam, and you see all the vaccination sites. It was back in 2008. So what you can see here is all the hospitals, all the public health service locations, not only the STI clinic, but also the facilities for drug users. You can see some GPs were involved, and also some places for people who use drugs. Then there was a main focus on the healthcare providers. What we did were quite a few things. There were yearly mailings, you know, old-fashioned mailings to specialists in the hospital and to GPs to inform them and to keep hepatitis B virus vaccination on their radar. There were articles published in Dutch GP journals, and what I really liked was there was a text attached to laboratory results. For example, if a GP asked for a test for gonorrhea and chlamydia, they got a result back with a note stating this person may be one of the risk groups who should be vaccinated for hepatitis B virus. Please do so or send them to one of the places where they can be vaccinated. I think that's a highly effective way. And it links to what we heard earlier today. If a woman comes for this abortion pill, attach information on PrEP, for example. We did do online and offline campaigns with lots of nice pictures, a lot of advertising on Facebook, on dating sites, on chat sites, but also outreach, doing on-the-spot vaccination, give the first vaccination on the spot, visiting gay parties, the gay prides, and really involving the community. Now the key question, did it work? Here you can see a decrease in hepatitis B, acute hepatitis B infections among MSM in Amsterdam. And here you can see that it worked, because this is, the blue line is new infections among MSM, and where the red arrow is when we started the vaccination. And you can see that it did go down. Now we know, but when we were starting the program, we didn't know whether it was working. And there were 3 evaluations done. I'll skip the first evaluation because you can all see that that's too early to conclude whether there's an effect or not. But I'll quickly show you 2 and 3. For the second evaluation, so there was, at a point, there was not yet a decline. It was published in in Vaccine, one of the medical journals, and it concluded that by that time coverage was low, mainly among MSM. I think it's very good that this evaluation was done, because measures could be taken to increase coverage. And this is the third evaluation moment, so the one when we clearly saw a decrease in incidence. There was some nice modeling done around it, and that showed that the effect that we saw fitted best the scenario where the 20% most sexually active MSM were vaccinated. So it seemed that the campaign did manage to reach those who were mostly at need. And they concluded, or we concluded, that the targeted intervention program has been proven to be effective. It can be done. So what can we learn from this targeted HPV vaccination? Well, it's put on the slide. The target program to include those at highest risk does work. We need good, mandatory monitoring. But let's look at this second point. We need good and mandatory monitoring to be able to evaluate our programs. And we should not forget that when we implement PrEP. We need active and varied activities. We need to offer the interventions at several locations. The more, the better. Long hours. We need, and that's another very important one, to have patience and a long-term commitment. If you evaluate your program too early, you won't see an effect. We need to work together, scientist, community, stakeholder, and we need to include positive messaging. Very short about HPV. Books have been written about it. I won't go into that. I did come to this official statement on the Catholic Medical Association position paper on HPV, and I'm always almost too ashamed to read it aloud, but significant, harmful, non-infectious sequelae of premarital sexual activity, mind you, increasing risk for depression, suicidal ideation, and future divorce. And related to other risky behaviors like tobacco, alcohol, and substance abuse. Then there are some people who are not activates for vaccination. We don't need those people, but we do need the opposite. People who are well known and who stand up for interventions that prevent people from getting diseases. We have a Dutch, very popular satiric television show. And the good thing is that this person, Zondag with Lubach, paid attention to vaccination and why it's important. And I think this is extremely important because He made it so much more fun, the message, and so much more palatable than our institutions usually do. So he explained the principle of cohort protection. If 80% or 90% is vaccinated, everybody is protected in a very nice and enthusiastic way, and I think that's something we do need. What can we learn from HPV vaccination implementation? When it's about children and when it's about sex, messaging is extremely important. I will conclude stating again, when it's about sex, framing is important. We do need positive role models. We need to keep going and look far ahead. Don't expect great results within 5 years or so. We need to focus on healthcare providers as well as key groups. We need scientists and activists and money. And monitoring, and I think you should make it mandatory because otherwise people won't put all this data in their program, is key for evaluation. These people helped me with putting together these data. Thank you for your attention.